This episode touches on sensitive topics, including sexual assault and domestic violence. Links to support services can be found in the show notes. Hi, this is Dr. Sanjaya. Have you ever wondered what forensic medicine actually involves or the important role it plays in police investigations? I sit down with Dr. Vanita Parekh for a fascinating chat about the vital work her team does every day. Let's jump into our chat. I'm delighted today to have with us Dr. Vanita Parekh. Vanita is a clinical associate professor of clinical forensic medicine at the ANU. She's a senior staff specialist in forensic medicine and sexual health at Canberra Health Services, and establishing and a former director of the clinical forensic services in the ACT. And just to add a cherry on the icing on top, she's got a well-deserved Order of Australia. Welcome, Vanita.
Thank you, Sanjay. It's lovely to be here.
Oh, it's lovely to have you. And look, you're in a field which I think excites and interests a lot of people, specifically because of all the TV shows around forensic medicines and what it entails. But tell me, for you, what does forensic medicine mean?
So forensic medicine is really where the worlds of medicine and law collide. And so we make things hopefully more understood in the legal setting about medical issues. But there's a clinical side to it, and that is the examination of victims and suspects, impaired drivers, for all sorts of different reasons, whether that's drugs and alcohol or other medical conditions. We look after patients in the city watch house or in the police custody. We'll write a lot of medical legal reports, and we present a lot of evidence in court and lots of legal writing and court reports explaining various medical terms to the general population, the lay population. So very akin to what we would do in clinical practice, and in fact we do have clinical practice, but where we're translating essentially the medical terminology and the consequences of specific injuries, for instance, and making it accessible so that legal decisions can be made based upon those.
As you've explained, it's not all about investigating murders. It goes far beyond that. How would you describe forensic medicine in the ACT?
So first of all, the first thing that I would say is that therapeutic care or looking after patients is always the priority. The forensic evidence collection is secondary to that. And we try as best we can to get the highest quality forensic evidence with integrity. So we're making sure that the right sample comes from the right patient, and that can be analysed forensically. And in the ACT, we're quite lucky because we're quite a small jurisdiction, which is fantastic for collaborative working relationships with the Road Transport Authority, with police, with the forensic labs, with the courts, and with the defence lawyers and the prosecutors. So we actually have this amazing jurisdiction where we can do so many things because we all, it's a small sandpit, if you like, and we all have to play nicely in that sandpit, but what we can get is fantastic results, and we can start to look at patterns that can't be seen in other jurisdictions because they are so large and disparate. So in terms of the forensic medicine in the ACT, there is one service, and that is the Clinical Forensic Medicine Service called CFMS, and I established that starting in the year 2000. And that service has got lots of different elements to it. It's got the sexual assault service, which was the initial service. And that started really after a particular incident that occurred in the year 2000, and that because of that incident, a sexual assault service was funded. Then in 2006, ACT Policing needed to have people to do general forensic medicine, and obviously we did that work as well. And then in 2010, we had a series of fatalities on Canberra roads on a very rainy day. And it just so happened that I was on call that day and had discussion with the person who was the superintendent in charge of traffic, because it was really all hands on deck that day, and asking about what was going on with these collisions and the impact of medical conditions on unsafe driving behaviour. And then in about 1920, we started to look at the research that we could do, not only from our own data sets, which I'd set up as established those services, but also how we could merge those data sets to track outcomes across the ACT. So that's been part of an incredible journey really over the last 3 years in terms of research, where we've actually been able to track outcomes right from when the patient presents until sentencing outcomes actually for specific crimes. So where we've got a victim, we can track it through police, through the Director of Public Prosecutions, through the court system, and then right through to the sentencing outcomes. You know, what did the conviction result in?
I mean, that's really fascinating, and I do want to take you back to that other point, just about the ACT being a wonderful place for collaboration. I think we've heard this from a lot of our other guests as well within the health service, that it's a small place, but it's got a lot of departments doing different things, but who are close together in real life, and therefore we manage to collaborate in a way that other jurisdictions can't. So that's the Canberra bubble, I guess, isn't it?
It is absolutely fantastic, and it's so underestimated. You know, we often look at these big studies from massive hospitals and we think, well, that's what real research is around, and actually it's not. It's about the patient or the victim or the suspect journey. And this is the ideal jurisdiction to do that. You know, where else can you walk to the coffee shop and bump into, and you think about how many times this has probably happened to you. There's Sanjaya. I must ask him about brainworms or whatever it is. You know, we have that amazing ability to interact with each other that really doesn't happen in lots of other settings.
Forensic medicine itself, as you talk about, you've talked about it as a process, I guess, at an individual level, because none of us in medicine, I certainly don't understand how it works. For you as an on-call person for forensic medicine, what would happen? You get a call from the police saying there's been a victim of sexual assault, then how would you proceed?
So the first and most important thing is that we, in the ACT, which is quite novel, we work with a nurse, and the nurse triages those calls. We then arrange where we're going to meet, and the first and most important thing is to make sure that that person is physically all right. I think we all get so worked up about collecting forensic evidence, but what do they need? What do they need at that time? What do they? Because it could be that they're really worried about getting a sexually transmitted infection or emergency contraception. Could be that they're worried about other people finding out. And in fact, 90% of victims are worried about someone else finding out, and only about 40% are worried about something medically being wrong with them. So it's really directed by the patient. And I use the word patient specifically because there's a therapeutic relationship that we have with patients, and there's a power differential in a clinical scenario, and we have to, as clinicians, understand that and make it as easy as possible for a patient to report and tell us things. And we know there's lots of barriers to reporting sexual assault, and in fact clinician attitude is a really big one. So it's about developing a rapport, and you know, the test of that is at the end of the consultation, when they walk out with a smile after something so horrendous. That to me is the magic. That's why we do it. So we would then sort of have a chat with them, and then if they can either decide if they want to report or if they just want to have medical care. Sometimes it's a really big decision and they're not sure if they want to report, in which instance we can offer what's called a just-in-case forensic medical, where we collect the evidence and it gives them a little bit of time to then decide if they want to report or not. So there's lots of different options. And the things that we'll be doing is asking them about what happened, to them. And we're not investigators, we're there to look after them. And medical evidence really in sexual assault cases is based on three things. It's DNA evidence, which we all hear about, and we see that, and we see the probabilities in the billions. The other things are toxicology evidence and the administration of substances, and also injury. And in fact, the commonest finding after sexual assault is no injury at all. And that's really important for patients to understand, because it's actually a barrier to reporting. When you look at media and you look at victims, they often, are very injured, and that's actually not the case. And so people think, well, have I been sexually assaulted because I'm not injured? And in fact, what we know about patients is, and I give this evidence regularly in court, is up to 70% have that freeze reaction where they look as if they're awake, their eyes are open, but they can't shout out, they can't move. Now, in no way does that imply any form of consent to what's happening. And 50% of people have complete immobility, they cannot move. And that's actually very scary for people, and it's much more likely to lead to post-traumatic stress disorder. So there's some really big myth busting that we do in court, giving expert evidence. So once we've collected that evidence, it goes under what we call chain of custody. So that means it's sort of the integrity of that evidence is maintained, and it's chain of custody, and then that can be handed over to the police if that's the route that person wants to go down.
So, as you've said, if the victim decides, actually, no, I don't want to proceed with this, even though the evidence has been collected, it won't be processed.
That's correct, yes. Okay. So, and we can't process that without their permission.
And you've certainly busted one myth there. I think a lot of us assume with sexual assault there'll be, because again of TV and the media, there'll be bruising and other evidence, because that's what we see on TV. But you've clearly shown that that's not always the case.
Absolutely, and as I say, people look at those images and think, well, that's not me, so I couldn't have been sexually assaulted. The one thing that is always true, though, is that the doctor that looks after people at 3:00 in the morning is always gorgeous. That's true in fiction as well as it is in real life.
Excellent. We'll definitely make sure that gets mentioned in the podcast. And you also mentioned the longer term issues with sexual assault, someone having post-traumatic stress disorder.
Yes.
Is there a provision for that longer term care that comes through that forensic medicine encounter at the start?
When that is reported, when that sexual assault is reported, don't have to proceed to court or anything, patients can then apply to the Victim Services Scheme, and they can get the psychological help that they need from that scheme. So, and that's partly funded through the proceeds of crime. So yes, there are other options, but I think the thing is about disclosing what's happened, and often we get really worried as clinicians or as friends or family of somebody, what are we going to do when they tell us that they've been sexually assaulted? And there's lots of good things. I mean, the first thing for anyone is to recognise that, my goodness, this person trusted me enough to be able to tell me what's happened to them. And that's an absolute privilege to hear that. And then the next thing is, you might not know what to do, but what you can say to the person is, look, I'm going to come with you on this journey. I'm going to help you as I can. I'm not sure what to do. And there's lots of resources like the Canberra Crisis Centre for men. There's the Service Assisting Male Survivors of Sexual Assault. There's a Domestic Violence Crisis Service, which is 24 hours. So there's lots, 1-800-RESPECT, which is 24 hours. So there's lots of different mechanisms by which people like us who other friends, family, patients make those disclosures to can actually get advice and help to support that person. But the great thing is, when they tell you, don't feel, oh my goodness, you should think, I feel really lucky that they've been able to tell me.
And look, I think an important take-home message for people out there who may have been a victim or suspect they know a victim that you've said is, people will believe you even if you don't have any marks all over you. It's not an uncommon thing. Just present and be aware that you'll meet someone who'll be friendly and willing to listen to you. So don't hold back.
Yeah, absolutely.
Yeah.
And they've trusted you. So that's a really important thing, that you don't break that trust for that person.
Now, Vanita, when you were talking about the various services that were available for victims, you did mention services for men. So how often do men get sexually assaulted?
So from epidemiological studies, what we know that about 1 in 20 adult males have been sexually assaulted.
Wow.
So it's pretty huge. And when you add in the childhood sexual abuse, it probably drops to about 1 in 6. So it's huge numbers that we're talking about. And it's a really...
And sorry, I am going to interrupt. Can I just ask what the figures are for women?
Yes, the figures are about 1 in 5 women. And when you take into account childhood sexual abuse, about 1 in 3 women.
You're kidding.
No, it's and you know, every time I give a lecture, one of the first things that I say to the audience is, this is going to have happened to people in this audience. You know, this is not an uncommon thing that happens.
Gosh.
Coming to men, we do know that they're much less likely to report. The levels of shame are really high, and embarrassment, and they're just very scared about coming forward. Mm-hmm. And so this is we did a study over an 18-year period. We looked at all males that came into our service. Now, of the male victims, 6.4% of all victims were males, adult males. And what we did with this group was we looked at lots of different factors, characteristics and demographics, but we also worked with our colleagues in ACT policing and developed a coded matching system where we could compare our data and police data without either group knowing anything about the identity of the individuals.
Wow.
And what we found in that was we were able to not only look at the patient characteristics, but we could track them through what happened in place, through the court system, and right through to conviction. So we did that study, and now we're working on the bigger data set where we're looking at the 93.6% of females in the data set, and we're actually going to run exactly the same process. But what we found in that study was that the collection of forensic evidence really probably tripled the conviction rate from people who didn't have forensic evidence. So with that collaborative working that we've done with police, and we've got police as authors on most of our papers, they are so excited by what we're doing, and we're sort of thinking, well, this is fairly sort of standard clinical practice for us, and they actually see massive benefits. And a bit like we were talking about earlier, they can see applications that we have no idea about. And in the male paper, what we did was we measured the core outcomes, we measured the health outcomes, we looked at rates of sexually transmitted infections, we looked at how much HIV post-exposure prophylaxis, so drugs that we give after sexual assault to prevent HIV. We looked at how many patients got that, how many continued treatment, what the follow-up rates were. And really what came out of it was the lack of support for male victims. It was quite incredible how unsupported they were. And also then, and what we've been able to do with that is work with police and talk about, let's have a think about how we support men who report sexual violence. So very, very common finding. And I think we're starting to see, worldwide, we're actually starting to see an increase in the number of female perpetrators of male sexual assault as well, which is something that hasn't really been described in the adult population. It's been described in the child population very well, but not with adults.
So look, that sounds like groundbreaking research that you've started in the ACT with this great collaboration that's been adopted by other jurisdictions in Australia. Is that correct?
We're certainly working with our colleagues around Australia and internationally. And all of our papers, everything's open access, so that if you're in London, you can look at these papers. And another paper that we've done, we've looked at non-fatal strangulation in the ACT.
So do you want to tell us about non-fatal strangulation, please?
Yeah, so non-fatal strangulation is something that we know is increasing in terms of reporting in all populations in all developed countries. And when I started in sexual assault, it was about 2% of our cases. Now it's about 25% of our cases.
Wow.
And that's over a 25-year period. When we look at things like domestic violence, it's about 50% of the cases that we're seeing.
And Vanita, so it can be its own thing, or part of a sexual assault.
That's correct. So it can be used. It can be part of a sexual assault, as you say, or it can be part of the family violence scenario. And what we found actually in one of our studies was that it was about 93% of people who were strangled or experienced non-fatal strangulation in the ACT, it was from a family member or a partner. So certainly in the domestic violence setting, it's also very gendered violence. 95% of our patients who presented were female. And what was really incredible in that study was that in 28% of patients who experienced non-fatal strangulation, their children witnessed what was going on.
Wow.
So then we think about what effect that has on that child growing up in terms of becoming a victim. Because if you grow up in a household with domestic violence, you're much more likely to become a victim. And there's also some data which really sadly shows that you're more likely to become a perpetrator. But it's not absolutely it's a small difference that we're aware of, but it certainly sits there. So I think lots of things came out of that collaborative working, again, with police officers. And, we saw the repeat offence rate in about 65% of cases. So what we know is that these offenders keep doing this to the same victims, and the presence of children for me is tragic.
It's heartbreaking.
The other thing that came out of that initial research was the need for forensic photography at the time of when police attend those domestic violence incidents. And we know that body-worn camera evidence, for instance, is really good quality. So we can have images of someone's body, or for their neck. I mean, obviously, yes. Not anywhere that's not exposed, but we can get all those images and we can actually look at them, and that again has a huge evidentiary value. Whilst we were doing that research, what we noticed, we were talking about logistic regression before we started, was that there's a strong association with eye injury and non-fatal strangulation. We found that in over 40% of cases, the people that presented after family violence had an eye injury. And we looked at this a bit more closely. Blunt force injury to the eye actually has lifetime consequences. We often think of just, a black eye and it has black eye. But actually it has much higher rates of things like glaucoma in later life. So these patients actually need to be screened for the rest of their life through an optometrist.
Wow.
And so, again, that's that collaborative working. What we did was, in this paper, we looked at the patients who had eye injuries, and because we wanted to illustrate what type of eye injury that was, we had to use a picture of somebody with an eye injury. And of course we couldn't use any patient images, so we found out about Getty images and we bought a Getty image and we used that. And so we put that into the paper, and we also worked with our colleagues in policing, and we said, look, one of the things doing this review of cases was, how do we photograph eye injuries? And we developed a scheme for photographing eye injuries. And what we did was, in this paper, we actually had, front of the face, eyes open, eyes closed, looked left, right, up and down. And we were talking to police about this, and one of the co-authors on the paper said, actually, we can have this on our evidence collection systems on the phones that police take out to every incident.
Wow.
So it tells police officers, take this sequence and of photographs, and they can be interpreted by an ophthalmologist in Japan. Anybody can look at those. So that evidence is there right from the beginning. And we not only rolling out across ACT policing, but also AFP, so the whole of the federal police, and New South Wales have picked up on it, and Victorian police. So we're getting, these findings from collaborative work are amazing. So we traditionally feel quite sort of what can we actually do in Canberra? Research can't be that impactful. Actually, we can be even more impactful. And we've shown that. The other thing that happens, and other police forces are taking this on board, are when police officers see an eye injury in family violence, they automatically ask about non-fatal strangulation.
Oh, wow.
And the victim liaison officers organise an optometry review for those patients within 2 weeks under Medicare. So they sit with that patient and go, look, you need to go and see an optometrist. I can help you book that in. And so these are, although they're small changes, they actually have got really big consequences, and we probably won't see the results of that for another 30 years. We're not going to be able to measure that, I don't think. But, if you can't measure it, you can't improve it. And that was Lord Kelvin, who was also worked at the University of Glasgow. Where I studied medicine.
No.
I wouldn't say I was from there. I was from Edinburgh. That was a pretty big paper in terms of what the implications were. So we're making these little steps in terms of how we address domestic violence in our community. Nobody has one fix-all answer. It's just these little things that we're going to do that will change practice.
It's extraordinary. And I was always thinking back to one of my tutors when I was doing a Master's in Applied Epi, and he would say, if you're ever doing research, just don't do it for research's sake. There's the so what factor. The so what is it going to do? Is it going to make a difference? And clearly this research that you've described is making a big impact, not just in the ACT, but in other jurisdictions and probably internationally as well. So that's wonderful to see.
Yeah, I don't think there's any point. No, I think Fred Hollows said something along the lines of no survey without service.
Yeah.
So, and we do need to think about that. And now we might not see the clinical applications, which is why it's really important to have different people on your research team. And I absolutely agree. I mean, I wasn't interested in doing esoteric research. This comes from being a clinician of 32 years and then thinking, well, how do we look at this to make a difference?
And in terms of recognising non-fatal strangulation, I can tell you many, many years ago when I was an intern or as a medical student, I can't ever recall being taught how to recognise signs of domestic violence. Has that changed now? If a woman presents with an eye injury to the emergency department, will have the doctors and nurses being trained to recognise it as potentially domestic violence or assault?
So that's really about the implementation of our research, and we're still doing the initial publishing in peer-reviewed medical journals, but absolutely the next phase of implementation, that will absolutely happen. So I think that, yes, so how do we get this message out to police? How do we get it out to emergency clinicians? One person can't do all of that. So having a combination of authors who can deliver it in a number of different settings is actually really important.
And just to go back to the eye injury as well. So with the eye injury, we're not talking about little petechial hemorrhages from the strangulation itself. We're talking about someone being punched in the eye during strangulation.
Yes, we're talking about all different types of eye injuries, actually. So it does include petechial injury as well, or petechial conjunctival petechial, but it does lid and conjunctival injuries were actually what we focused on.
Right.
So yes, you're absolutely right. It's from the direct application of blunt force to the eye.
Okay. And Vanita, we've talked about testing for STIs in these victims. As you say, many of them are so traumatised when you first meet them, that's even a secondary thought for them. How often are STIs a consequence of sexual assault in men and women?
So we did publish a paper with some fantastic colleagues from Canberra Sexual Health Centre, and it's very difficult because of the nature of testing to determine whether the sexually transmitted infection arose from the sexual assault or whether it arose from a pre-existing infection.
Yeah.
And that's because the tests that we've got for sexually transmitted infections now are so incredible that they pick up the smallest amounts, which is brilliant, but it doesn't help us work out who got an STI from the sexual assault. So even we don't actually know, and I don't think we'll ever find this out. Was it from a pre-existing infection? But what we did find was that patients were willing to be tested. They wanted to be tested. Yeah. And that's fantastic. So what we can say after sexual assault is, let's test you. Our results really did show a prevalence in keeping with what we have in our general population in Canberra. So we can't necessarily apply that to, say, Northern Territory, where STI rates might be higher.
Sure.
But what we did find was that patients really wanted this testing. And the other thing was, despite doing a lot of logistic regression, there were absolutely no factors that were associated with the acquisition of STI. So you might think things like the number of assailants, for instance, or the level of genital injury, and we couldn't find anything. And that just about drove me a bit wild, because I was trying to find a factor and I actually couldn't find it. But what's really exciting is that we've got people who've done the same research in Norway and also in Ireland, and they found exactly what we found. So we know that this is a real result. And in fact, I'll be off to work on some international collaborative work with the Irish, which is really exciting, and thinking about, because they want to learn how we've done this case tracking, for instance, and it's quite straightforward. So we're going to work with the Irish potentially to look at that, so that, you know, you always, I think, and you'd be aware of this, when you get research out, you're thinking, oh, somebody else got in before me. But actually, what it does is it confirms that that person's research wasn't isolated or once off. So we all have a role to play in that. And it's not just victims that we see, we also see perpetrators.
Oh, right. That's interesting.
And so we've described a lot of perpetrator demographics as well. We do take forensic specimens.
Vanita, I'm just going to ask, why would you get asked to see a perpetrator?
So for lots of different reasons. Firstly, to see if they're fit enough to participate in a police interview. So there's lots of things that influence how somebody might behave in a police interview, and these include medical things. So, for instance, if you haven't had enough sleep, if you haven't slept for 17 hours, your psychomotor retardation is as if you're at 0.05. If you haven't slept for 24 hours, your retardation is about 0.1, adding on top of that any alcohol that someone might have consumed. Now, we wouldn't expect someone to be a safe driver at 0.1. So why would we expect them to be able to calculate their own advantage in a police interview situation?
Highly stressful situation.
Yes. Yeah. So, you know, and that's about getting good evidence. It's about the admissibility of this evidence. We don't want false convictions. False convictions are really bad. That's where somebody has been convicted wrongly. They end up potentially in prison or something like that for something they didn't do, and the real perpetrator is out walking around. So we need to be able to minimise the chance of a false confession, and that's through sort of fitness for interview assessments, but we also take specimens, forensic specimens from suspects, and that can be very useful when we're looking at tying those cases together. So, and obviously some of those sites cannot be accessed by police, parts of the body and things like that, and so we might have to take those specimens. So, and we also provide medical care to people in police custody, and about half of people, up to half of people who are in police custody aren't there because they're there for any criminal reason. They're there because they can't look after themselves because they're too intoxicated with alcohol or other substances or something like that. So actually that is the missing piece. You know, we actually need to make sure that the evidence that we get from suspects is robust, and that's absolutely a critical role for a forensic physician. So it's not always about victims, it's about a whole range of other issues.
Vanita, I think we could keep talking for ages, but unfortunately we have to draw this wonderful discussion to a close. You've taken us in depth into the world of forensic medicine, talked about the amazing research you've generated here in the ACT with collaborations that you can really only do in the ACT, and talked about the jurisdictional and international implications of that. Thank you so much for coming in today to speak to me, and thank you so much for the wonderful work you're doing in forensic medicine.
Thank you, Sanjaya.
Thank you for listening. I hope you'll join us behind the curtain for our next episode, where we'll delve into the story of another of our fantastic health professionals here at Canberra Health Services. If you're interested in starting an exciting career with us, head to our website to join Team CHS. And that website is www.canberrahealthservices.act.gov.au/careers, CAREERS. I acknowledge the Ngunnawal people as traditional custodians of the ACT, the land I'm recording on, and recognise any other people or families with connection to the lands of the ACT and region.